Now, we know that the use of imatinib doesn't have any deleterious effect on transplantation, but we have very little information about those patients who are the classical patients who reach transplantation today, have been exposed to imatinib, perhaps dasatinib, and later nilotinib, as in our case. Now, the EBMT has concluded very recently a prospective study of patients exposed to all three, in nilotinib and dasatinib, specifically for the outcomes of transplantation after exposure to those two agents. Now, you can see that the chronic phase patients, or patients who reached the transplant in first chronic phase, still had a very good survival of around 70% at 5 years, while the patients who reached the transplant in advanced phase do a lot worse. Now, the choice of TKI is interesting, since the majority of patients who were exposed to dasatinib are alone or in combination sequentially, as our patient did, and very few patients were brought to transplantation having failed only nilotinib prior to transplant. Now, this is also important because there seems to be a difference in the way we bring these patients to transplantation. This is the disease status at the start of the second generation TKI, and you can see 46% were in chronic phase, the rest were in advanced phase. But by the time they reach a transplant, the number of patients in chronic phase has decreased, and the vast majority of those patients have progressed. That seems to be more often this progression in patients who had been brought to transplantation following sequential use of dasatinib, nilotinib, sometimes even ponatinib and bosutinib. So this is an example of our patients as well. Now, the main objective of this trial was to look at differences between the two drugs, and there was no differences at all in any of the transplant outcomes, engraftment, acute and chronic GVHD, overall survival, relapse incidence, or non-relapse mortality. There were no differences also in the EBMT score in the three groups. And these results are very much comparable with the results you would expect with patients treated only with imatinib. So the conclusion is that the addition of dasatinib or nilotinib prior to transplantation doesn't seem to have a deleterious effect, apart from the fact that you bring the patient later to transplantation. Now, the trial confirmed a couple of things that we knew already, that the EBMT score is important, although there doesn't seem to be a huge influence of the lower numbers of EBMT score. Here you can see the no patient score 0. All patients at least has 1 point because of the 12 months interval between diagnosis and transplantation. And it's only after you reach 4 or 5 points that you can see a deleterious effect of the EBMT score, reflecting the more advanced phase. Performance status and, of course, the stage chronic phase versus the rest is also important in predicting outcome after transplantation. At this point, I'd like to ask the second question to the audience, and since you've already been bombarded with some data about transplantation, if hypothetically our patient, instead of had developed the M351T mutation, which seems to be very benign, and in this particular case didn't prompt the indication for transplant, if the patient had developed the dreaded T315I mutation, what would you have done? Would you have switched to ponatinib? Would you proceed it exactly the same, assuming that you achieve MMR as well, performed an allotransplant there and then, or only proceed to transplantation if the patient had disease progression? Please vote now. Okay, most people would still ask the patient to go for a trial of ponatinib. Again, this reflects what the normal current clinical practice is, which is we only consider transplantation as a last resort, and we find every excuse we can to try and not to do a transplant, and if we find a different TKI that we haven't used, we will still try to do that instead of proceeding to transplantation. And as you've seen in Michael Deininger's talk, we may have something like 25 different options of TKIs and non-TKIs treatments in the near future. So the word last resort really has a different meaning here for transplantation. And I have to say that I probably agree with most of the audience, because even if you would expect me to say that transplantation in the T315I mutation status is the best option. There is data to suggest that if the patient remains in chronic phase, as in the top curve, the comparison between the ponatinib-treated patients in the PACE study and a selection of patients who had the T315I mutation, the comparison between the chronic phase and the ponatinib-treated and the allografted patients seems to favor ponatinib, at least in this short, medium term. This curve doesn't seem to have a plateau and eventually may actually cross over. But at the moment, if you have a T315I mutation and you progress to advanced phase, including Philadelphia positive ALL, probably you need to have a transplant. And if you remain in chronic phase, ponatinib may be still a sensible option. I'm going to skip this last two slides and go directly to the final slide, which is my interpretation of the possible role of allogeneic stem cell transplantation in patients with CML in the current era. I divide the patients into two categories: those who have primary failure, that is, after the most judicious use of all BCR-ABL inhibitors available to you, and that includes anything between 1 and 25 different compounds. You give yourself something like 1 to 2 years to achieve a complete cytogenetic remission. And you heard today that you probably don't need to go to molecular remission to live forever. Complete cytogenetic remission, in my opinion, is enough to avoid a transplantation. If you're not in CCR after 2 years of very good use of TKIs, then you have a very good reason to proceed to transplantation, especially if your EBMT score is low. However, the vast majority of patients will not fail the judicious use of all available TKIs and eventually achieve a good response. Now, not all of these patients will remain in a good response, as you've seen in the previous case. Over the years, perhaps some of these patients, anything between 15 and 20%, may lose that response, may lose the cytogenetic remission, and then you have to use the rest of the TKIs available to you according to comorbidities, toxicities, and the ones you used before. But here the time frame should be more limited. You have to make decisions regarding transplantation within a year, maximum 18 months. And if you're not in CCR, then you've seen that the overall outcome for those patients not responding to second-line therapy is not very good, and an allogeneic transplant, in my opinion, could offer a much better chance of survival to those patients. Thank you very much for your attention. I'll take some questions.